Even also, if you can just remember to put your questions and answers in the Q&A box and not in the chat box. We will still have the QR codes today. If you want to scan them, we've posted them on the Telegram as well. So we will display them just now for you all to just scan them in a few minutes. And then at the end, we'll also have the scan at the end. So if you can just look at the, let me just get to the scan that you can scan it. Okay, so there's the start code. So all of you that already had the Sochon participation app downloaded, if you open it up, press the middle button, you'll be able to see that you can scan the code and you'll get your attestation afterwards if you scan the N code as well. So I'll give you a minute or two to just scan these. We are looking into who's going to attend at least 70 to 80% of these webinars for the next 6 weeks. And then from there on, we will be able to see who we would be able to send out a certificate for attending most of the webinars as well. And there will be another series after this that we will give you more detail in due course. So if you can just all scan this, and it will be able to give you the attestation. While you're scanning, I just want to welcome our panelists as well that's on our panel. We've got people from Africa CDC. We've got Professor Shadei from our ICANN chair as well. We've got people from CDC and from African Union as well on the call, and then from ICANN as well. So if there's any questions that you want to post, just please put it in the Q&A box. I'm going to stop sharing now. We will put this again up afterwards. But I would like to start, that we can start with the program. I'd like to introduce Susan Kezi from Africa CDC, and she's going to do the introduction on COVID-19 status in Africa. Over to you, Susan. Thank you. You're just still muted, Susan.
Yes, good afternoon to our East and West Africa participants, and good morning to West, North, and Central Africa participants. Welcome to Africa CDC ICANN IPC webinar for COVID-19. My name is Susan Kesi, a public health fellow with Africa CDC. I will give you the update of COVID-19 as of 9 a.m. East African time. Yes, so this slide shows the epidemiological situation for COVID-19 globally. The map to the left shows the distribution of COVID-19 cases by country across the world. The darker color indicates the countries that have reported over 100,000 cases since the pandemic began in January 26. Countries including South Africa have reported over 100 cases to date. The panel to the right shows the epidemic curve showing the trend of COVID-19 cases reported daily by 6 WHO geographic areas. This slide shows the trend of COVID-19 cases from February to date. The epi chart depicts the number of new cases reported by day, and 7-day moving average is shown by the red line. Over the past 4 weeks, the number of new COVID-19 cases being reported per week has decreased from 58,000 at the beginning of September to 51,000 in the past week. In the past week, an average of 7,396 new cases were reported per day. Cumulative, there are about 1.4 million cases have been reported, over 35,000 deaths, which gives the CFR of 2.4%, 82.6% of recoveries. This shows the situation by African Union regions. We can see the new cases as of 29th September 2020. There are a total of 6,699 new cases, 213 new deaths, and 6,065 new recoveries. This slide shows the distribution of cumulative cases, COVID-19 cases reported by African Union member states. On the left are 5 categories. First is countries for reporting less than 500,000 cases. The second is countries that are not showing a sustainable increase or decrease in new cases reported, and majority of the countries are in this category. There are 7 countries that are showing a downward trend in cases reported, while 3 countries, Cabo Verde, Libya, and Tunisia, are showing an upward trend in new cases reported. This slide shows the webinar report. We finished the last week, we finished our series 3, and we have started our series 4 today. So this slide shows series 3 participation and registration. As you can see, we have had 1,705 total English webinar registrations and 747 for French registration, which gives a total of 2,452 total webinar registration. So the graph shows the cumulative total of registrants categorized by French and English. To the right, you can see a line graph. This shows the number of participants per webinar, in which we have total of 1,078 total webinar participants for English and 327 total webinar for French, which gives a total of 1,405. This is only 57%. This shows that only 57% of people who have registered have attended the webinar. We also send out a survey to know why the people who have registered have not joined the webinar. So we would appreciate if our colleagues they can fill out the survey so that we know what we need to improve. This shows the English webinar registration by location. We can see most participants are from Nigeria, Kenya, South Africa, Ethiopia, Ghana, and Zambia. We have 10 countries, AU countries that are not represented, which are Benin, Central African Republic, Comoros, Mauritius, Angola, Cabo Verde, Equatorial Guinea, Eritrea, Libya, Sao Tome and Principe. Please, if you have colleagues in these countries, you can forward the registration links so that we can have participation from these countries. In attendance, we had 29 non-AU countries that were represented. For French webinar, we can see top countries represented is DRC, Burkina Faso, Cote d'Ivoire, Cameroon, Guinea, and Burundi. We have 18 Francophone countries in Africa, in which 3 of them were not represented in Series 3, which include Cabo Verde, Equatorial Guinea, and Seychelles. In attendance, we had 13 non-AU countries that were represented. We have a Telegram group, Community of Practice. For English, we have 809 people who have joined, and for French, we have 215. The 2 graphs, the first graph shows from the survey that we sent to people, we have done the analysis, so majority of the participants strongly agreed that the Telegram group of Community of Practice is a useful follow-up platform. And the second graph shows that majority agree that questions in the Telegram group were answered. So this is to say that the Telegram Community of Practice group is a very useful group. So if you're yet to join the group, I will put the link in the chat box so that you can join and participate in the group. Thank you so much for listening.
Thank you very much, Susan. What is happening, and it gives us an idea of what's happening in the world as well, but especially in Africa. And it's always good to see the amount of people that actually joined our webinars as well. So really, please, I want to urge all of you to just also register on the Telegram, and you can also keep on posting your questions on there, and we will be able to answer you. From now on, I would just want to like to introduce Dr. Mervyn Wenger from Zimbabwe. Dr. Wenger is a specialist obstetrician and gynecologist at the Yanatwa group of hospitals, if I pronounce that correctly, Dr. Mervyn. He's also a member of the Zimbabwe Society of Obstetricians and Gynecologists, and he's also a member of the National COVID-19 IPC and Case Management Pillar in Zimbabwe. Please, I want to hand over to you, Dr. Mervyn, to present to us your presentation. Thank you.
Thank you very much, Anna. Welcome everyone from wherever you are. Let me just share my screen. Okay, can everyone see?
Yes, we can see.
Yes. So yeah, so this is very interesting, and thank you very much for the invitation. I very much appreciate it as a young gynecologist to be able to present to an international forum. So I'm briefly going to talk about safe surgery and maternal issues in COVID-19. I've tried not to make it too scientific and also not to go too much into the clinical area, but please bear with me. Sometimes I just got carried away. So the objectives of the first presentation will be basically on safe surgery. So it will be introduction, the continuation of surgery, procedural considerations, practical measures, all vis-a-vis to do with infection prevention control in our settings. So COVID-19 reported, the first case was reported in China, Wuhan province on the 31st of December. Then subsequent events happened. That is in February, people realized and who named it as COVID-19. And then in March on 11, it was then declared a pandemic worldwide. And this definitely had an impact, not only on health, but it also affected the way that people socialized, their entertainment, their economy, sources of living, and all aspects of life basically were affected. Even zoos were closed, so animals were not even spared. But however, of note is COVID has come, it is with us, and it has changed the way medicine and surgery is and will be practiced, as well as our social interactions and the way that we do things. And the initial response for COVID-19, I would say it was regional, it was continental, and at times country specific, depending on the load or on the burden of disease that was detected. And the initial response from the majority of the countries was to impose massive lockdowns and also advocate for quarantining and isolation of people. So these massive lockdowns, they had the good result of trying to reduce the reproductive rate of the virus to a level of less than 1. But however, it also affected service provision in other non-COVID related healthcare products. So early on, society and governments realized that in order to achieve some victory against COVID-19, there was a need to maintain and improve the existing infrastructure of healthcare systems and also increase the capacity to deal with increasing anticipated critical care needs. If you remember, during the early onset of COVID-19, it was all issues about ICU beds, the availability of ICU machines, the availability of ventilators as people tried to expand their capacity to deal with COVID-19. And as a result, some other healthcare and healthcare service provisions did suffer due to this. So in the absence now of effective drug therapy and vaccine timelines, we all know that people are anticipating that we are going to have vaccines this year, but we know that it might be next year or it might be the end of next year. So the timelines on the existing situation are actually uncertain, and it means that we will have to make preparations. The services that we had closed, slowly we are going to reduce the restrictive measures. We are going to relax them to avoid negative implications due to these delays. Because we do have patients who have been on chronic medications, maybe medical, those that are diabetic, those that have hypertension, that were being followed up in our chronic ailments clinics. And these at one time were totally shut, especially in my country, in Zimbabwe. So uncertainty that is with us means that patients may be deprived of access to care. But however, we will talk about this considering surgical care and also maternal services. So initially on the 30th of March in 2020, the American College of Surgeons realized the need for capacity building, infrastructure sparing. Then they put out a statement that noted that there was a need to prioritize appropriate resource allocations as it relates to elective invasive procedures and minimize the use of essentials required for care of patients. So basically what people were saying is during this time when we had many countries being hit hard and there was an increase in terms of the cases of COVID-19, it was necessary for us to close all elective procedures so that we then go and reach the peak, and then we go past the peak, then we might consider opening up the doing of elective surgeries. And this was all meant to try and spare and also improve the availability of critical staff. That is, make sure that ICU beds are available, make sure that the anesthetists, they are doing and dealing with critically ill COVID-19 patients, and also to minimize the threat to other patients. Because if you have a surgical patient with COVID-19, if you mix them with patients who are non-COVID, then they are at risk of getting infected. And also it was for protection of the healthcare worker, who is not an infinity resource. They are limited, especially in our African countries. So this was from the surgical perspective. But however, if you go to the College of Obstetric and Gynecologists, many of them, be it the American College of Obs and Gyn, the South African College of Obs and Gyn, as well as even in England, they even WHO itself put out a communique showing that there was a need to continue antenatal, intrapartum, postpartum care to pregnant women, and also to continue providing reproductive, maternal, neonatal, child, and reproductive health services, even at the peak of COVID-19. This is well known that it will reduce the complications that are okay in pregnancy and also reproductive issues. So with the continuation of safe surgery, the strategy, according to the American College of Obs and Gyn, was there is need to have a regional cooperation to continue providing care. That is, in those countries where people can afford and they have unlimited resources, you can then decide to designate some part of your hospitals or different hospitals altogether to say that this is only a COVID-19 treatment facility, so that you don't have the mixing of patients, those that are COVID positive and those that are COVID negative. But however, we know in Africa we are resource limited and we have constraints. We have a shortage of hospital beds before even COVID came into place. So in my country, in Zimbabwe, what we then did was to sort of like demarcate the hospital and divide it into two and completely seal it from the other half, so that the other one would become the largest COVID-19 referral facility in Zimbabwe. That is about 412 beds. And also about 30 HDU and ICU beds, just to try and be prepared. Then they also note that there is need for a good supply chain. That is need to ensure that there's adequate supplies of vital equipment. That is the CPAP machines, the ventilators, more so protective, personal protective equipment. This has been a source of contention amongst the healthcare workers due to fear of being infected, fear of infecting their loved ones if they got infected. So this is very important from an administrative point of view to make sure that adequate PPE supplies are actually put in place as we try to revamp or as we continue to offer some form of a service in this COVID-19 era to our patients. Then there are issues to do with COVID-19 testing within a facility. This is good if resources are permitting, because it reduces the turnover time for you to get results, referral of patients to private laboratories to go and get tested. And this is meant to protect staff from patients, because when you then know that this is a COVID-19 patient, for instance, at Parenyatwa, there's a COVID-19 theater where people get operated on in COVID-19. Then they are not mixed with the non-COVID patients. And this also protects patients as well. But however, there are issues to do with when do you test the patients, how do you test the patients, and also issues to do with the healthcare workers themselves being tested. So another point to take note is case prioritization and scheduling as we resume or as we continue our surgeries. So they are what are called essential surgeries and non-essential surgeries. So the essential surgeries are the ones that are a time that will affect the outcome of the procedure. Then we have the non-essential that are basically non-time limited and usually elective procedures. So that table just tries to give us an example of the emergence, which are the vascular injuries that should be done as emergent as possible within 1 hour. We have the urgent one within 24 hours. Then in red, there you can see I put scheduled cesarean sections. And these are urgent because you can have a leeway of about 2 weeks. But of note is for all these conditions that are there, they have the possibility of actually upgrading themselves from the discretionary elective surgery to an essential elective. You can have a hernia, a patient who has a hernia, and then it strangulates. This patient then moves from the essential elective list and becomes an emergent case that needs to be done there and then. So the surgical societies realized that all elective surgical endoscopic cases at the height of COVID-19 had to be postponed until such a time that we had gone beyond the cave, and also until we had learned enough about COVID-19 and the waters had calmed. And their recommendation also is, and this still stands, all non-essential hospital staff should be at home, and the teleworking should actually be promoted as much as possible. But however, being in Africa, issues to do with internet accessibility, how much it costs, also affects our ability to actually be able to use teleworking. So in-person education had to be kept to a minimum when it's absolutely necessary, but it should actually be done online. Then multidisciplinary team meetings should be held as virtually as possible. This is when you have complicated cases that you might need to operate, and you might need to consult your seniors or an expert who actually has done a number of cases. This improves outcome. You might need to actually do it as virtually as possible. Then during the ward rounds, we don't want unnecessary large numbers of people because it increases the chances of infection. So we need to then minimize the number of people who attend ward rounds. Then on procedural considerations, that is when you then have a patient and you decide that this patient you would need to take them for theater. So we do have what is called minimally invasive surgery, where you are actually using laparoscopy. You make tiny little holes, maybe 10 millimeters at the navel and 5 millimeters, and you put ports and you can operate from there. This is good. It gives you good surgical visualization because you have magnification. It also reduces the risks of damage to surrounding structures. Then also cosmesis is good, and also recovery time has actually been noted to be fine versus the conventional approach, which is just opening the whole abdomen and making maybe a 10 centimeter or a 15 centimeter incision on someone's abdomen. But however, evidence is still evolving regarding the relative risk, because we know that during this procedure, there could be aerosolization and vaporization of viruses that are in the blood. But with COVID, evidence the jury is still out there. Then there's a possibility to given to viral contamination to staff during surgery. And this has nothing to do with the method that has been used. That is the open approach, the laparoscopic approach, or the robotic approach. So protective measures have to be adhered to, employed as effectively as possible, so that we then reduce any risk of infection of these individuals. Then also, as I mentioned earlier on, laparoscopy actually gives you reduced hospital stay because the incision is small and the recovery is much better. And these also need to be considered. But however, the learning curve for laparoscopy is very long. So if you have good laparoscopic surgeons, senior surgeons, they should be able to take up the opportunity to do the cases. But however, if you have people who are not so conversant with laparoscopy, it means that it will take us more time to do the procedure. Then it means that it's not the best method to use. Then enhanced risk of viral exposure of proceduralists, that is if you have patients who are doing endoscopy, those that are manipulating the airway, the anesthetist, you then also need to make sure that they are protected. So practical measures for surgery. It is very important that if you have a patient that you then consider you want to take them for surgery, you need to have an honest discussion with the patient regarding the risk of them getting exposed to COVID-19 and the potential consequences. This is very important because we know that the sensitivity of our DNA PCR, the rapid one, is actually 70%. So it means that it will miss about 30% of people who actually have COVID but are not yet shedding the virus. This is also very important because of studies that have been done. For instance, one study was looking at patients who, over 1,000 patients who had surgery done on them, and 25% of these patients had COVID-19 detected before surgery, and then the 75% of the patients had COVID detected within a period of 30 days after surgery had been done. And it was at different centers looking at about more than 1,000 patients. What these individuals noted is 50% of the patients actually ended up having some form of respiratory complication. So it means that it is wise for patients who are COVID-19 undergoing elective surgeries that they should be managed and then declared COVID-free, and then theater can actually be done. And it was also noted that 20% of patients who are of the 1,000 patients actually ended up passing on due to complications of COVID-19. So this is very important and requires you to have honest discussion with patients. Then you also have issues to screening of patients. For instance, someone is an elective patient who is coming in for a myomectomy or a cesarean section, or someone who is coming in for some other elective procedure. Patients should be tested preoperatively for COVID-19. So the question has been before admission or on admission. So you find out there are different guidelines. If you look at in the Americas, Johns Hopkins Hospital, what they were doing was to say patients can be tested 24 to 72 hours from the day when they are supposed to be admitted. But these patients would then need to quarantine themselves so as to reduce the risk of then getting COVID infected after the screening test had been done. But however, we can also be able to do a COVID test on admission. That's why we said that there should be in-facility testing so that we improve the turnaround time. But however, knowing what is happening in our African countries, the availability of the DNA PCR machines, the turnaround time, this might actually not be possible. So it is best that every patient, even though they have been tested, and if they are an elective or an emergency case, they should be treated as COVID positive patients, irregardless of the DNA PCR result and irregardless of whether they are asymptomatic or symptomatic. Then we have one question that poses problems. We are saying patients should always be tested. Then what about the healthcare workers? So should they be tested every day because they are getting into contact with different kind of patients? They are also going to their houses. So the CDC tries to clarify this and says that there is no need for healthcare workers to be swabbed and their DNA PCRs done on a daily basis, but should only be tested when they are asymptomatic, and those that are symptomatic are encouraged not to even present themselves to their workplaces. But however, screening should continue in the form of questionnaires. That is, they should be asked about the symptoms of COVID-19. Are they coughing? Do they have a fever, nasal discharge, and so on? So this is deemed to be enough. So in the operating rooms, for presumed cases, these should be appropriately filtered and ventilated. And if possible, we should have different for other emergent cases. So it means that ideally we should not be mixing patients who are COVID-19 and those that are not COVID-19. And if facilities permit, we then need to have negative pressure rooms, especially when patients are being ventilated, because these are aerosol generating procedures. So if you have negatively pressured rooms, this actually reduces the risk of transmitting or getting health workers infected. But however, I should say in my country, even our biggest hospital, Paranyatwa, we actually had to have engineering works done to revamp the ventilatory system in the hospital, and this has been ongoing, and I'm happy to say that it's functioning. The anesthetists are happy, even the surgeons are happy in terms of their assessment that they've done. So only those considered essential staff should be participating in surgical procedures. So it means that we need to have a minimal number of people that are going to be in the surgical room, except only in the case of an emergency where you might then need assistance from other healthcare workers and other expertise. It is also important that all members should be in PPE as recommended by the CDC or the World Health Organization. Suffice to say that every patient who is in the hospital should have some face covering on, and in theater we expect the minimum to be a surgical mask on, but you might have to go to the FFP2 or the N95 mask so as to reduce the risk of transmission to the patient. Then in terms of procedures, there is a thought that electrosurgery units need to be set to the lowest possible settings for the desired effect. And this is basically as a result of the thought that they can actually lead to particle aerosolization and increase the risk of infection of the healthcare workers that will be in theater. So surgical equipment should be used during procedures with COVID-19 or in suspected patients, and these should be cleaned separately from other surgical equipment. Then having said that, it is important that the healthcare workers feel that they are actually protected, because this then motivates them to actually come to work as well. So I would say, as far as surgical procedures, safe surgery, this is as far as I had gone, but I will entertain questions. I think after the second part of the presentation, you can ask any even clinically related, and I will try my best to be able to answer those questions. So being an obstetrician, definitely I would not have done justice to my societies and women without talking to maternal issues in COVID-19. So the background of this short presentation will be a background framework of quality of care. What is the risks of COVID-19 and mother with newborn baby? How can we protect and ensure safe environment for both mothers? Recommendations for mother and child before, during, and after delivery. So it is of note that the World Health Organization, even in 2016 before COVID, talked about the standards of improving quality of maternal and newborn care in the health facilities, identified that the period around childbirth and immediate postnatal care is the most critical for saving the maximum number of maternal and newborn lives and preventing stillbirths. This is the reason why I said we have to continue with offering maternal and child health office services as much as possible. So their framework basically, sorry for the poor quality of the picture, is a quality of care framework. It talks about 8 stems, and of note is the one that is important to us is number 8, which is essential physical resources available. So statements on the point number 8. The first one actually says water should be readily available, sanitation. Then they're highlighted in red. It's actually infection prevention and control, which is what we are talking about. There should always be good hand hygiene, and there should also be good waste disposal facilities. And they should be functional, reliable, safe, and sufficient to meet the needs of, 1, the staff, which are the health workers that we are talking about, the women who are our patients, and also their extended families and families that would want to make sure that the quality of childbirth is actually improved. So areas of labor, childbirth, and postnatal care are designed, organized, and maintained so that every woman can be cared for according to their needs in private to facilitate the continuing of care. Then we should have adequate stocks of medicine, Supply chain should be maintained, adequate PPE. We should also have the correct equipment for our patients, and these should be available for routine care and management of complications. So effective infection prevention and control plays a significant role in reducing maternal and newborn deaths, right? Neonatal and maternal sepsis accounts for up to 11% of maternal deaths worldwide, together with bleeding and also in my country, hypertensive disorders of pregnancy. So it means if we practice good IPC, the usual hand washing, surfaces are clean, the face mask, it means that we can actually play a role in reducing the number of maternal deaths in our countries. So for this picture, it's basically trying to show the number 8, whereby it's talking about the basic services in hand washing, limited services, hand washing facilities with soap and water, which should be maintained at all costs. So prevention in the community, because remember, our women do not just become pregnant and find themselves in the hospital. They are always in the community where they will be living. So social distancing should be practiced by these women. They should avoid going into crowded places, hand washing and wearing of face masks. These are all hygienic measures that are actually not new and that are recommended as we try to continue with service provision. But however, it is also good for us to note that we do have homeless women, and it might be difficult for them to adhere to the above principles. We have women in shelters. For example, in my country, we have what are called waiting homes, where mothers in the rural areas who stay distant from the hospital can actually come maybe 2 weeks before at 36 weeks and lodge there, and then so that they are at the hospital. If they need an intervention, then it is done as soon as possible. So this might actually be difficult for them to have social distancing, avoiding crowds, because these facilities, when they were built to accommodate high volumes in low spaces. Then we also have multi-general dense housing structures. As Africans, we have the extended family system. So you'll find that the woman that you'll be managing within the community actually stays with 5 more adults, 3 more families, as they share resources. And this is very important because they themselves can do social distancing, avoid crowds, but the other members of the community or of the family might actually be potential sources of infection as they go about their daily business. So we also need to realize that our women live in multiple places at the same time. This is like, for instance, we have a woman who has a high-risk pregnancy who stays in the rural areas, and they are supposed to be seen at a provincial or a central hospital. It means that when they are nearing their time or date of review, they will have to move from their home and then go and live with other relatives who stay near the hospital. And this then affects our community prevention strategies. So patients with a potential exposure, that is patients with an epidemiological history of contact with a suspected or confirmed case, should self-isolate and be monitored for symptoms. This is very important. So at my institution, we have at the gate, when all patients are coming in, they are supposed to answer and be screened using a questionnaire. And those that are noted that they might have a risk, then they are informed and are directed to be managed. It is important that we recognize that the incubation period of COVID-19 is 14 days, and the diagnostic testing depends also on availability. So being in Africa, in Zimbabwe, sometimes the woman presents in a peripheral rural hospital, and these tests are actually not available. So this might actually reduce their chance of being assisted, or it might actually prolong the case management that needs to be instituted. So further evaluation depends on the severity and underlying comorbidities and clinical status. This then becomes the case management. If you then have a COVID positive pregnant mother, then you then need to assess them, cohort them, decide whether they are mild, moderate, and severe, and refer them for appropriate management. The care of the uninfected women. So guidance is available from societies, and we should also note that this is the bulk of our women, because COVID-19, just like the flu viruses, usually affects about 2% of the population also. So its fatality is about 2%, sorry. And so most of our women basically are not COVID positive, and we should be focusing on these ones. So their management should actually be tailored for whether the pregnancy is actually high risk or is a low risk pregnancy. So the majority of them, less than majority, which could be 80 to 90%, especially in my country, are usually low risk patients. So we need to promote telehealth, whereby patients simply call their doctor or send a message to their doctor during this COVID time, so that we then try to reduce as much as possible patient-doctor and patient-patient interaction and coming into close contact together. Then we also need to reduce the number of in-person visits and the timing of visits. So if you then have patients who are low risk, who are not infected, and then they are admitted into an institution, we then need to make sure that we don't have any visitations that are not necessary. And at my institution, or at institution where I work, we then, sorry about that. We then are making sure that we only have one visitor at a time. Then when you are managing these patients, you might need to group a number of tests. You have antenatal tests that are done for pregnant mothers, and you also have ultrasound scanning. So you might need to group these tests. Instead of doing them a week after another, you might need to then say maybe at 13 weeks or at 16 weeks, mother, you should come, and then you do all the tests at once. This reduces their interaction with the healthcare worker and also at the lab facilities, so that they do not get COVID-19. So we need to restrict maternal contact with others, restricting visitors, and also testing even the visitors. There is a study that was done, I think it was in New York, where they were looking at companions that came into the labor ward, and they tested this. They noted actually that about 20% of them actually had COVID-19 and were asymptomatic. Then timing and frequency of indicated ultrasound scan, instead of doing ultrasound scan once weekly or twice weekly, you might then need to do it after a certain period of time. So during these visits, healthcare workers should practice the usual social distancing, frequent hand washing, sanitization of surfaces, wearing of at least a surgical mask, and no partners should ideally be allowed into the consultation room because of limited space. And if it is possible, we then need to facilitate video communication. But however, being in our countries, it might be difficult. We might not have as yet set up the facilities for video communication. And you find out this actually also reduces the quality of care that mothers will receive. Then delivery, what we need is we need a pre-hospital notification, so that the facility can make the necessary precautions. So women, when they are getting into labor, before they just pop up, they should actually communicate with the receiving institution that this is what is happening. They are now in labor and they are coming, so that the necessary precautions can actually be taken with regard to infection prevention and control. All patients should be screened for signs and symptoms of COVID-19, as well as the contact status before entering the hospital for admission. For this one, it is very important, because if we go back to a study that was done also in New York, where they looked at about 230 patients who came into labor and they were asymptomatic, they actually found out that about 13% of patients, when they did screening with DNA PCR, these patients were actually COVID-19 positive, meaning that they were posing a risk to the other patients. So it is very important that we should not slacken on doing temperature checks, asking the history about new cough, sore throat, abnormalities of smell and taste, and if it is possible and facilities permitting, it is wise that we actually do a DNA PCR test, but this should not be at the expense of instituting emergency care to our women. So before admission.
Sorry, I just asked you to, we have to start wrapping up, please, otherwise we're going to run out of time. Thank you.
It's okay, it's okay. Few slides, I think. So pregnant patients with suspected or confirmed case should notify the obstetric unit prior to arrival. Then we should also identify the most appropriate room for labor and delivery, then ensure the availability of PPE. Then they should also inform the personnel, as I said before, so that we can then be able to prepare for the arrival of the patient. Then all staff should be trained on IPC before the patient arrives. Then this also is the same. Ensure that the staff are correctly trained, limit the number of visitors, as I previously mentioned, Then we also need all visitors to be masked and screened. Visitors cannot go to any other location but their patient's room so that they do not get into contact with other surfaces. And appropriate signages on mask and social distancing should be available. So the CDC recommends the testing of pregnant women with suspected or those who develop admission. Asymptomatic and pre-symptomatic patients may present in labor as implications for staff and newborn. So in areas of with high community infection rates, testing of all patients on presentation is very important. Use of PPE in labor ward. So this has been a bone of contention, but it is thought that women, when they forcefully exhale, this may reduce the effectiveness of the face mask. So it might be necessary, if they are available, to put your patients on the N95 and also the healthcare worker to use the N95. Support person may be allowed, but these will not leave or re-enter the room so that they do not bring in COVID. And those with symptoms of exposure should not be allowed to attend to their delivery. And if screening is negative, then face covering. And if you have additional support that is required, then it should be via a video conference and not in person. Labor, routine labor. So the indications for cesarean sections do not change. The indications should be the same, not that a person is COVID-19. And suffice to say that SARS-CoV-2 has not been detected in vagina or amniotic fluid, but in feces, so that's good. IPC practice should be maintained. The infants of COVID positive mothers should be considered suspects and should be isolated from other healthy infants and cared for with infection prevention measures for suspected or confirmed cases. But however, delivery, routine delivery and initiation of breastfeeding should be within the first hour. If a patient has COVID-19, they can be discharged when clinically indicated, or if patient has not met the criteria to discontinue isolation, she can be discharged home to self-isolate. Mother-baby contact, temporary separation has been proposed, but has adverse consequences with regards to breastfeeding and bonding. So WHO has recommended that routine care should be continued. Neonatal care, there is no contraindication to feeding, breastfeeding. There is no evidence of transmission through breast milk. So the mother should wear a face mask, practice good IPC when breastfeeding the mother. So this, I think, comes to the end of my presentation. I think we will attend to any questions and any corrections. I thank you.
Thank you, Dr. Marvin. We will have 2 questions and answers at the end. I'm just going to ask Lizzie Chetole, the ICANN training coordinator, distance training coordinator, to take us further with her presentation, and then we'll have all the questions at the end of that handled by Dr. Iwande. Thank you, and over to you, Lizzie.
Thank you, Anna. Good morning, good afternoon, and good evening to everyone, depending on where you are. I'm just going to briefly share with you the overall IPC issues in the neonatal unit and in the ICU. So for the outline of the presentation, I'm going to talk about the IPC considerations in the neonatal intensive care unit, and also touch briefly about the care of a neonate born to a COVID-19 positive mother, and also touch on the personal protective equipment consideration for healthcare workers in the neonatal unit. And just as an introduction, the neonates in a healthcare institution are at risk of infection, especially those that are in the neonatal ICU. The colonized neonates are the major source of infections, and as we all know that the microorganisms can be transmitted between the neonates on the hands, equipment, or patient care supplies. So basically this borders a lot about the healthcare worker infection control practices, and also on when it comes to hand hygiene on the nursing mothers. And this often results in further colonization, in infection outbreaks, and an increase in morbidity and mortality. So the infection control factors that must be considered in any neonatal unit is we first and foremost, we all know that the neonatal units are very busy places, especially in Africa. And we know that the premature babies remain hospitalized for long periods of time. So basically, this means that the longer they stay in hospital, the higher the degree of them contracting infections. And then the staff have to access the healthcare areas and work safely. And this borders mostly now with regards to COVID on the PPE issues. And then the equipment and supplies must move in and out safely. That means that we should be able to have dedicated equipment for the neonates. And we should have dedicated areas where they are cleaned. And then the medical devices also used have to be processed in the proper way. And above all, the environment must remain clean, and the dirty or used items must be removed, and they should be clean and sterile items that are brought into the unit. So the neonates are particularly vulnerable to infection because of all those reasons that have been highlighted there. But what I'm going to touch mostly on is the poor infection control practices. So for the breastfeeding and COVID-19, as Dr. Renge alluded earlier on, we know that active COVID-19 has not up to date been detected in the breast milk of any mother with either confirmed or suspected COVID-19. And because of that, it appears unlikely, therefore, that COVID-19 could be transmitted through breastfeeding or by giving breast milk that has been expressed by a mother who is confirmed or suspected to have COVID-19. And basically, as we know, the research is still ongoing. And once there is any new information, it will be updated. For the best practices that are needed in the neonatal unit in terms of infection control, we need for each patient contact, we have to emphasize hand hygiene. As hand hygiene, as we all know, it has been proven to reduce 80% of the infections in the hospital. And when we have the patient contact, appropriate use of gloves and apron. And these mostly, when we talk about the gloves and apron, we'll be referring to the contact precautions. And then what is also important in this neonatal unit is that we have to clean the equipment and have a schedule, for example, which is 12-hourly decontamination, while in, and also between the neonates. That is, as you move from one neonate to the other, there should be cleaning and decontamination of the equipment. We should also have a clean environment, because if there is clutter, things lying all over, then chances are, even if it means we are doing care activities, we are then likely to pick up items and use them from one neonate to the other. Then we also have to prevent contamination of clean and sterile supplies before use by making sure that things are stored in the proper places. We also need to perform correct, clean aseptic procedures, and especially the problem there, which usually arises, is when we're looking at the WHO 5 moment for hand hygiene, which is moment number 2 before a clean or aseptic procedure, the right time when the moment 2 is supposed to be performed. And then also what is important is that we have to isolate the neonates that are colonized or infected with significant pathogens, as Dr. Renge earlier on alluded, and we limit the transfer of neonates between different wards and rooms in order to limit their exposure to pathogens. And all of these actions must occur in an environment and with the necessary engineering support that helps the healthcare worker to be compliant with the expected standard of care. Then when we look at provision of a hand hygiene, where the gold standard now is the alcohol hand rub at the point of care. And these are examples of where in the neonatal unit you can actually place the alcohol, a hand rub at each point of care for each particular neonate. And then the functional spaces, that is the patient rooms, the space between the beds, it has to be at least 3 meters in the neonatal ICU or 2.4 meters in the special care. And we also have to pay particular attention to the oxygen points, the suctions, and the electrical points. This should be preferably in the wall and should be easily cleanable. And then for the cleaning room, where we are going to clean the patient care equipment, it should be a dedicated room, and the requirements should be a deep sink where we are able to properly clean, and also a work surface that can accommodate drying. For the ward milk kitchen, the sink has to be available also to clean the milk containers, and we have to have working refrigerators where we store the express breast milk and the formula milk, and this should be labeled, and the refrigerator should be clean. Then in the kangaroo care, we should ensure that there is adequate storage for personal belongings of the mother, that is outside the room, and there should be dedicated bathroom and toilet facilities, and there should be a place to eat, for example, like a ward kitchen, whereby the mothers do not have to be having meals where they are nursing these babies, and they should have a dedicated area where they can sit comfortable and be able to express breast milk. In the cleaning room, we also have, that is our sluice room. There should be a sink to clean cleaning equipment, a slope whopper, and a working surface, the storage space for the cleaning trolleys, a hand wash basin, and the space to hang the mops or the floor sweeps or the cleaning clothes. And then when we look at the requirements or what is needed for any neonatal ICU, we have the bed number. We can ideally, we are supposed to have 2, and if we need to cohort, we can then make sure that we practice cohorting effectively. The space, as we said, it should be 2.5 meters between the beds. The isolation room door, ideally, it should be clear glass door, which is either button activated or sliding. This is what is preferred. The ventilation, it should be neutral pressure, and this is essential. The water supply, it should be a water-free zone, or basically now, due to the evidence that is coming in on the use of the hand washing basins for literally everything, it would be better to have these sinks outside the isolation room. The alcohol hand rub, it should be at point of care, or it should be wall mounted and freestanding in the room. And this is actually essential. The cleaning equipment, there must be one dedicated cleaning cart, and this cart should not move from the isolation unit to the general ward. The bedside cabinets, there should be cabinets with drawers, and these should be kept outside the room for personal protective equipment and for the patient notes and files. This is basically also essential. The storage or the resuscitation trolleys, they should be 2, and they should be kept outside the room. And this is very important, and it's regarded as essential. The equipment, there should be sufficient equipment so that there is no sharing of the items, and this is also essential. Then for the terminal cleaning, as we know that there is so much diversity in Africa, we should ensure that we perform terminal cleaning according to the hospital IPC policies. So for the care of the COVID-19 sorry, for the neonate that has been exposed or born from a COVID-19 mother, the neonates were admitted to the neonatal ICU soon after birth, usually asymptomatic, and most of the times they are not exposed to symptomatic visitors or healthcare providers. Because remember, as we said, that effective screening should be done so that we ensure that if the healthcare workers meet the criteria, they can go and isolate at home, or the mother can be isolated in another room. And again, the universal masking for visitors and healthcare providers, as well as hand hygiene, proving to be key important factors to ensure that there is no transmission of COVID-19 to the neonate. And as we know, or what Dr. Wenge was saying, that the baby might have been exposed to COVID-19 during delivery, and for such neonates, then they should be put under contact and droplet precautions, as they might be in the incubation period of the infection. For the care, the IPC considerations and the PPE that comes with it is we are going to practice the contact and droplet precautions as the way in which we are doing now. And if we are not resuscitating the neonate, or if there are no aerosol generating medical procedures, what we only require is the mask, of the face shield, or goggles, or gown and gloves. But if we are now resuscitating and there's also aerosol generating procedures, you should then substitute the procedure mask with a respirator. And then you always have to contact the site IPC focal person concerning the delivery or the care of the baby. Then for the suspected or COVID-19 positive mother, we have to delay skin-to-skin contact for the neonate until the mother is able to do hand hygiene and to don the mask. So it's very important at this stage that soon after delivery, when the mother is now settled, we offer health education and we teach them how to perform proper hand hygiene and how to properly don the mask. And we always ensure that the mother performs hand hygiene and wears a procedure mask before holding the baby until they are proven to be negative. If the neonate is stable, but the mother has been hospitalized for other reasons, you still maintain contact and droplet precautions, and you do not discharge the baby, and you consider the virtual or phone pediatric consultation, as Dr. Wenge was saying, and the mother or the family of that neonate, if they are positive, they cannot visit the neonatal ICU. So in this case, there has to be a nurse who assists with the express breast milk or the formula feeds, depending on what the mother would have or the family would have chosen. And then you consult with your local IPC focal when there's the COVID exposure, and as defined, you should have an essential visitor screening questionnaire prior to entering the neonatal ICU. As we all know, in Africa, we have different upbringings, we have different beliefs, and a baby belongs to the whole community, so the grandfathers, the grandmothers would want to see the baby, or if the mother is not able to see the baby, maybe the other parent or the caregiver would be wanting to have access to the baby, so they have to be screened every time prior to entering the neonatal ICU. And then all the maternal patients, which is the mothers, they should be screened for new or changed symptoms using the COVID-19 symptom identification and monitoring tool once every 12 hours. And then you arrange for the public health and clinician follow-up post-discharge, because they will require close community follow-up. Then for the feeding of these neonates, breast milk is the healthiest source. And as we know, for now, the COVID-19 has not been detected in the breast milk. So it is safe to breastfeed the baby. However, there are many unknowns about the COVID-19, and each family has its own context to consider. The families should also participate in the decision to use breast milk for infant feeding with the support of the healthcare providers. And if there's a temporary separation, the mothers who intend to breastfeed should be encouraged to express their breast milk to establish and maintain the milk supply. Thank you, and also a big thank you to Sister Marina Ocamp from the Unit of Infection Prevention and Control, Tygerberg University, where some of the slides I have borrowed. Over to you, Anna.
Thank you very much, Lizzie. Yeah, thank you very much for this presentation as well. I think both of them goes hand in hand to really give us a broad idea of what is happening and what we can do. I'm going to hand over to Dr. Yewande to take us through the questions. There wasn't much in the question and answer box, so I don't know if she would just want to maybe take now and then take it from there. Over to you, Dr. Yewande.
Thank you so much, and thank you to all our speakers. It's been quite interesting. Just to let participants know that we would like you to put your questions on the Q&A chat box. That is the way we can answer some of your questions. I see someone's hand is raised. Please just put your questions and we will be able to address accordingly. Also, we are live streaming on Facebook, so our Facebook participants can also drop questions relevant to the presentations made today. And our panelists from Africa CDC, from ICANN, from US CDC, Resolve to Save Lives, and also from the experts who have spoken today will be able to address accordingly. So I think the first question I would easily direct to both of our speakers, Mervyn and Lizzie. If you can speak a bit about that, then I will also find out if other colleagues on the call will be looking to speak about that. So can a baby acquire COVID-19 during delivery from a positive mother? I know you've talked a bit about that, but I think it might be helpful for you to speak to that a bit more.
Okay, thank you very much. If I could take that one. So what is of importance is this question is a bit broad. So if the baby is in utero, is surrounded by amniotic fluid, there's currently been no detection of COVID-19 in amniotic fluid that surrounds the baby. There's also been no detection of COVID-19 in vaginal secretions. So it means the birth canal out, when the baby comes out, is clear of COVID-19 and there is no risk there. But however, knowing the birth process itself, remember that COVID-19 is also detected in stool, that is in maternal feces. So that could be a chance for infection, though the jury is still out there. Then you also have other things where you start initiating contact with the mother. That's where you actually have the greater risk and potential for infection of the baby from the mother. But the amniotic fluid and the vaginal secretions do not currently have not been seen to have COVID-19.
Lizzie, I don't know if you would also like to speak a bit about that.
Thank you, Dr. Yewande. I think Dr. Wenge really explained it at length, and it's very easy to understand. Thank you.
Okay, fantastic. Any of our panelists want to add on to that? Or please keep your questions coming so that we can spend some more time on the Q&A. So colleagues, live streaming from Facebook, do we have any questions from Facebook? We'll be happy to take that. Otherwise, I think it's definitely looking like a short Q&A session this week. There's some of the questions around the technicality of this, and I think it's important we talk a bit about that. Anna, I know that you had mentioned during the housekeeping, but it looks like it always pops up. So maybe you can take this time to explain to participants how, particularly for people joining us for the first time on this webinar series, how the QR code, what the app, while we just wait for other technical questions to come up. Over to you, Anna.
Thank you, Wanda. Yes, I'm just going to go back to the beginning so that people can see how to download the app. So what they need to do is to be able to go to their Google or iPhone store, and they look for the PDA Participations app, which they can then download. This app will give them the next, as I can show them the next slide, it will show them where to sign up. You put in your name and your telephone number from where you are, and then it will send you a one-time PIN to your phone where you would need to enter to carry on. That is just to verify that you said who you are. As soon as you've done that, and that's why we always try to ask people to download this before the session, because it's difficult to do it if you're in the session already. And also, if you use your phone to view the webinar, it's also going to be quite difficult to do that at the same time. So it would be easier to do it before the time, and then you can download the QR codes and scan it afterwards as well, because we make it available for the whole day for you to be able to do that. So as soon as you then sign up, you will be able to see the app looks like this. And if you press here in the middle button, and you've got the QR code that we've displayed, the minute you show your phone to the screen, it automatically tells you, welcome, that you have started to join this webinar. And at the end, as soon as we are done and we show you the end code, you scan it again, and it will then automatically tell you that you've actually have signed in for this, and you've got your attestation. It will tell you attestation, and you can actually download it, and you can print the certificates to show which one you have actually participated in. So you'll see here's a sample of Susan. Here's her details, and then here's when she downloaded the QR code, and this one will give you the attestation. So it's actually quite easy to then get to this and download the apps and the QR codes. Each session's got their own unique code, so you can't scan the codes afterwards or a day later or whatever. It won't work. It's only valid for the period since the session starts until 2 or 3 hours after the session. And then every week they've got their own unique codes. So here is the start code again. So if you do have the app, you open it up with the middle button, you hold it close to the screen, it will actually then show you that you've actually started this session. And as soon as you've done then with this one and the session closes, we will show you the end code. You will scan the end code, and it will actually then also tell you that, thank you, you've done this session, and here you can get your attestation. So this is the end code that you need to scan. And then also I want to just give you, this one is a link for the Telegram community of practice, so that if you click on this link, you can actually join and you stay on there, and it's also free. We actually download a lot of information from Africa CDC, the QR code is all on there. And if you have got any other questions after the sessions or in between different sessions, you can post it on the Telegram community of practice, and any of the experts of the panel, of the the variety of panelists that we've got, will be able to access that and give you an answer. Okay. So I'm just going to go back to the end code. If there's anybody else that wants to ask anything, I'm going to hand over to Dr. Wanda. I see there's a new question there that she can then just handle. Thank you. Over to you, Dr. Wanda.
Thank you so much. I didn't realize I was muted. We have a couple of more questions, and please keep your questions coming around safe surgery, maternal and neonatal health. This question again would be open to the floor of panelists. So I'll start with Mervyn, then Lizzie, and other panelists on the call who would be happy to speak on this. Is it safe for COVID-19 positive breastfeeding mother to use cloth mask during breastfeeding? So again, I think just to add a bit more context is talking a bit about the safety COVID-19 positive mothers should consider in terms of caring for their babies, in terms of during breastfeeding and things like that. So over to you, panelists, for your input.
Okay, thank you very much for that question. So ideally, when the mother is in the hospital, they ideally are usually given a surgical mask depending on the availability of the surgical mask. But however, a cloth mask is good enough. And always remember that there is the standard 3-ply cloth mask. Lizzie maybe will elucidate further on that. But all we need is for the mother to have the mouth and the nose covered all the time, social distancing, hand washing, practicing the proper IPC all the time. The reason why this has been said to continue breastfeeding, it's lessons learned, I think, from HIV and AIDS, whereby people used to say, breastfeed. If you don't breastfeed the baby because of COVID, the baby might actually suffer from malnutrition and die. So if they practice good IPC, face mask, the cloth mask, hand washing, social distancing, it should be good enough and it should work. Thank you.
Thank you. Are there other comments from colleagues on the call? Prof, Elizabeth, Karen, Lizzie, Anna, if you have any other comments?
Yeah, sorry. I just wanted to add to what Dr. Vingi said. If the mother is confirmed positive, as he said, it is preferred that she uses a surgical mask because that has is better as a source control than the cloth mask. But if she doesn't have it, then she should use the cloth mask, 3-ply, as he said. So where the mother is a confirmed positive, we much prefer, it is more advisable to use the surgical mask. But where that does not exist, a 3-ply would be acceptable. Thank you.
Yeah, this is Elizabeth from CDC. I would echo what Prof just said, excuse me. And I would also say that the mother should be taught too that if the mask, the cloth mask is soiled in any way or gotten wet from her secretions, then that mask needs to be laundered and she should use another mask so that the baby is not exposed to, closely to someone who is using a soiled or potentially contaminated mask. Over.
Thank you. May I just add on to that? I think we can take a message out from here so that we actually give good advice on the floor. That if we have mothers and there's no, they do not have one with, and they're going to use cloth masks, we should really ensure that they have many, and more than one. They should have at least 3 or 4 or 5, because really it's all about that contamination. So if they're going to use cloth masks, then they should have a number of that so that they can clean and launder when it's dirty. Otherwise, they're going to use one all day, and that's not safe for the baby. Thank you.
And just to reiterate, hand hygiene, of course, for the mother, we take it as a given, but new mothers.
Karen, can you please be louder? Can't hear you.
Just to reiterate, teaching moms how to perform hand hygiene is critical. We in IPC assume everybody knows this, but obviously they may not. And I think when we're on the floor before discharge for COVID positive mom, you'd want to know what the home situation is like. If there's no water, you know, she's going to need to be provided with some alcohol-based hand rub one way or the other. So these are all considerations that, you know, we have to think about, and it's not quite so simple. Thanks.
Thank you. I think those are really interesting points that as our discussion has sort of brought up. Thank you so much. Here's another question. It says, can we separate the newborn from the mother? I know that Lizzie mentioned a bit about encouraging breastfeeding and a bit of close contact with the mother to nurse the baby, but I think it might be helpful if you speak a bit about that. Lizzie, the floor is yours.
Thank you, Dr. Yawande. And like we're saying that you delay a bit as you teach the mother, because what is important at that particular time is we do not want to expose the baby. So we have to ensure that the mother is properly taught on the IPC aspect, that is the proper donning of the mask, and like what the other IPC issues with which Karen mentioned, whereby you have to tell them that if the mask is wet, they have to change it. You teach them, you emphasize on the proper hand hygiene, because there is a risk if you just give the neonate to the mother when they are not properly taught on the IPC issues. Thank you.
Thank you so much, Lizzie, for that. I think finally we'll take one question, then we can wrap up the Q&A session. We're still keeping our eyes on the Facebook live chat, so if you've got questions, please send it, and our moderators on the channels will be able to send it our way so that our panelists can address that. So it's just going back again. I think we need to re-emphasize nursing for nursing mothers and care of neonates. It says, I know that you answered a bit, but can a positive COVID-19 positive mother breastfeed neonates immediately after delivery? I know that there's research that has been done extensively around identifying the virus in breast milk, and I don't think there's enough evidence to tell us otherwise, but I think you as the experts speaking on that may just give our participants some sort of better understanding. So over to you, Lizzie. I know that you mentioned that during your talk.
Thank you, Dr. Yawan. As we said, and the current evidence that is there, that the COVID-19 has not been isolated in breast milk, so we still encourage the mothers to feed their babies. But what is important, as I earlier on said, is to ensure that all the IPC aspects are adhered to. You give the mother the surgical mask, you teach them hand hygiene, and they can safely breastfeed the baby without any problems. Thank you.
Fantastic. I think there's some other question. There's a question around, is there any evidence why the number of cases in Africa is less compared to other developed countries? Is that low testing, and is that for any reason? I think that's a rather interesting question. But I think just to say that it wouldn't be because of low testing, because I know that we, as this outbreak really started as an organization, as the Africa Union, along with our other key partners, one of the things we try to do across the 55 countries of Africa is strengthening that laboratory capacity and diagnostic capacity with our private public philanthropic organizations. I think we were able to ramp up testing in a short while. I think there's so many things that as global health experts and researchers, everyone is trying to understand better what the possible reason is. As it is, there's no hard-cut evidence on why our cases are particularly low as you would expect compared to other countries. But there are other factors such as the fact that Africa has a sort of younger population compared to some of the other continents and other countries that was greatly affected, which could have been a contributing factor. So there's so many factors that may have contributed to this. And I think one of the things we also as an organization, and I'm sure that my colleagues on the calls as experts are also looking at, is to better understand what is really favoring Africa in terms of the trends that we see currently. So I think I'm just looking at to make sure that I have not missed any question and doing a quick check on Facebook to see that we haven't missed anything. And on that note, I think I can just hand over to Anna to take us through the final bit of the webinar. Over to you. And thank you so much to my panelists for being on this. And thank you so much to the speakers for today.
Thank you very much, Wande. Yes, I want to just thank everybody. Thank you to Dr. Wenger and thank you to Lizzie for the great presentations. Thank you for the panelists to have your time to be available to answer the questions that was in the box. And I know that some has also been looking at the Telegram. Thank you, Susan, for the overview of what is the status currently in Africa. And as we said, we are welcome to just keep following us next week as well at the same time. There will be also a French session on the same topic on Friday. So every Friday there will be the French session and every Wednesday will be the English session. If you've got any other questions, please don't hesitate to contact us and we will see how we can answer you. And thank you very much for everybody. Thank you. Goodbye.